from London and very interested in infection immunity, and she will present some topics more in relation to adult immunology. So happy to have you here. Thank you, Emma.
Thank you very much, Despina, and thank you for inviting us. It's really fabulous to be back in Athens. I was last here over 20 years ago, so it hasn't changed very much. It still looks terribly old. So thank you. So we've focused slightly on younger patients so far today, but not by design, really. But what I really want to focus my 20 minutes is about talking about how we manage adult patients who have inherited immunodeficiencies, and actually when we think about the role of bone marrow transplantation in adult patients with immunodeficiency. So firstly, I want to set the scene by just drawing your attention to the natural history of patients with various inherited immune deficiencies. And I've just given some examples here. So Wiskott-Aldrich syndrome, this study here shows the overall survival of patients into adulthood. And this is years at the bottom. And you see that this is 29 years here. So by the time patients get to their early adulthood, their expected overall survival is poor. And likewise, for patients with DOCK8 deficiency, Fabio was discussing that, the overall survival, this is 20 years, 30 years, 40 years, and their event-free survival is extremely poor. Patients with common variable immunodeficiency, which I think we've agreed is not a specific disease, but is a description of various forms of either antibody deficiency or antibody deficiency with other additional complex features, can broadly be separated into a group of patients who do extremely well on immunoglobulin replacement therapy and essentially have a normal life expectancy. And there's another group of patients who have features of autoimmunity, liver involvement, gut involvement, lymphocytic infiltration of their gut, diarrhea, nodular regenerative hyperplasia in their liver, portal hypertension, autoimmunity, cytopenia. And these patients do really badly. So as an adult physician looking after patients with inherited immunodeficiencies, we need to be thinking about, is there anything we can do to intervene to try and prevent this progressive decline in quality of life and also the really quite appalling overall survival? Because you could argue that these are progressive diseases and patients, very few adult patients will have a normal life expectancy and most of them will die in their mid-adult years. So there are a number of therapeutic options for adults with immunodeficiency, which can be general supportive care, which we're all familiar with, appropriate antimicrobial prophylaxis, immunosuppression if indicated for autoimmunity or inflammatory features, immunoglobulin replacement therapy, for example. And then some patients who have been identified through genetic screening to have specific mutations can be treated with targeted therapies. For example, not anti-CTLA-4, but CTLA-4 agonist abatacept for patients with CTLA-4 insufficiency, PI3 kinase delta inhibitors, for example, in patients with APDS, and JAK-STAT inhibitors for patients with molecular defects in that pathway. Targeted therapies are relatively recent. They can have a really significant beneficial impact on disease symptoms and slow progression of disease. But for most of these drugs, the durability of the response in terms of years of duration is not yet well described. So we don't know how durable these therapies will be and whether patients will become refractory to them over time. So in the curative treatment bucket, we have stem cell transplantation and gene therapy. And just one word before I move to transplant on targeted therapies is they're clearly only appropriate or applicable if a targetable defect is present. And there's some really nice data, for example, emerging for patients with STAT1 and STAT3 gain of function who've received JAK inhibitors, who have had really good clinical responses. But the challenges, which I think I've just mentioned, are how do we prevent off-target effects? How do we titrate the dose and the effect? What do we measure? Because we don't measure the levels of these drugs. How do we measure the efficacy? What's the therapeutic window? For some of these, it's quite small, so the toxicity is high, and how do we minimize side effects? There's a long-term requirement in inherited disease, and these drugs can be expensive. There are adverse effects in the short term that we're aware of. We don't always know what the adverse effects in the long term are. And none of these targetable agents actually correct the antibody deficiency as yet. So let's move to allogeneic transplantation, because it's my thing, right? But also, there are a number of things we have to consider. What is the potential benefit of transplant? Because it has to outweigh the risk. And this is really basic, simple stuff. If you're a transplanter, every patient you see, you have to weigh up the risk versus the benefit of the transplant. This is not necessarily actually important for the referring physician or the referring immunologist. If you think someone has an inherited immunodeficiency where the mutation is within the hematopoietic compartment and is potentially correctable by a stem cell transplant from a healthy donor, I would recommend referring to a transplant centre for a discussion, because there will hopefully be someone there who has the experience to make subsequent decisions. There are now international MDTs that discuss these rare patients in adulthood. So in inborn errors of immunity, graft versus host disease, which we find beneficial when we treat leukemia and lymphoma, is not beneficial. We don't want to kill any host cells in the recipient who's being transplanted for inborn errors of immunity. We want to minimize the toxicity of the conditioning chemotherapy, which is given to eradicate the recipient's hematopoietic stem cells. And we absolutely want to optimize engraftment of stem cells and the subsequent immune reconstitution, because that is why we're doing the transplant. We want to create a normal, adaptive, and innate immune system. So compared to adults with hematological malignancies, which is the broad bulk of adult patients who go forward for transplant, PID patients are different. They often have severe comorbidities and end organ failure. They often have an infectious sort of preload going into transplant with resistant, persistent, or refractory infection. And really importantly, which makes the whole clinical area difficult and decision-making difficult, is many of these particularly newly described diseases, we have very little information on the natural history of these diseases. So when we're trying to compare the potential benefit of going for a transplant, which may have a transplant-related mortality risk of 10% or 20% or 30%, the more we know about what would happen if we don't transplant the patient, the better, because that helps us make that judgment call about whether the patient would benefit from transplant. And so I encourage people working in non-transplant immunology to collect data, to follow patients so that we know what the long-term natural history of these diseases are. Also, obviously, in inherited disease, siblings and family members are potentially also affected by the same mutation, can be carriers, and aren't always the best donor for stem cell transplantation. Another major problem for us are genetic mutations in a family where there's really marked clinical heterogeneity. So you have a group of people, you have family members who have the same genetic mutation. Some of them are extremely sick and some of them are completely well. And that is a real challenge. The extremely sick one, you might think, right, you need a transplant because if you don't have one, you're going to die. what do I do about your brother who's 2 years younger than you or 2 years older than you with the same mutation, but you're completely well? Should I transplant you? Should I wait until something horrible happens to you? Should I transplant you now when you're well and the risk of transplant is lower? And for some inborn errors of immunity, that is a really difficult decision to make. For others, there's very tight genotype-phenotype correlation, but not for all diseases. And then finally, lack of data, right? There's still very few adults who've been transplanted for inherited immunodeficiency. So when should we consider transplant? My flippant answer is when patients have demonstrated a severe clinical phenotype, but before they have developed too many complications. And that's really difficult, right? You know, it sounds an obvious answer, but it is really difficult in practice. So some of the flags for referral for transplant are the presence of life-threatening infections, bone marrow failure, refractory or poorly responsive autoimmune or autoinflammatory disease, malignancy, and HLH. So the risks of not discussing or referring for transplant early are that some patients will have a rapid deterioration. For example, they'll have a hepatic decompensation, develop ascites, varices, and then they will be too unfit to go forward for transplant. Or other patients, for example, patients with bronchiectasis on long-term immunoglobulin replacement therapy develop progressive bronchiectasis, and by the time someone considers transplant, their pulmonary function is insufficient to safely get them through transplant. So these are pictures from my hospital. This is actually our young adult transplant unit. For those of you who are not transplanters, the patients get admitted. They have conditioning, which is usually a combination of various chemotherapy drugs to kill off their hematopoietic stem cells. Usually that takes about a week. They then have an infusion of their healthy donor stem cells through an IV catheter, and within about 10 to 12 to 20 days, depending on the conditioning, they will engraft their stem cells. And by that I mean the stem cells will have migrated into the niches within the bone marrow compartment. The donor hematopoietic stem cells will have kind of settled down, looked around, thought this is a bit weird, the stromal cells are new, not sure about this, and eventually they start to divide, produce progeny which differentiate, and the first cells that emerge from the bone marrow into the peripheral blood are the neutrophils, which start circulating, and the first sign you have that a patient's engrafting usually is the appearance of small numbers of neutrophils in the peripheral blood. During this time, patients are profoundly cytopenic, and I counsel patients that although they've got an immunodeficiency, actually we can make them worse in that period of time. And then in the next few months after engraftment, we have patients on systemic immune suppression to prevent the alloreactive graft versus host disease process. So immune-competent donor cells arising from the transplanted stem cells can recognize alloantigen presented on normal tissue in the patient, be triggered to activate, proliferate, secrete cytokines, cause a cytokine storm, tissue infiltration, inflammation, which we refer to as graft versus host disease. So this is an immune-mediated response from the new donor immune cells against the patient's own tissues, often focused on the skin, the gut, and the liver. So patients will be on systemic immune suppression for at least 3 months and often much longer, depending if they develop graft versus host disease. So patients have to know about this because they'll be clinically in a situation that for many of them feels very much like their original disease, and they'll start questioning why the hell they've come to have this transplant. So I'm just going to update you on a paper that the proofs were sent into Blood last week. So this is hot off the press. This is an EBMT and ESID study that I led with a number of different colleagues across Europe. And this was a retrospective study of adult patients who'd undergone allogeneic transplant for immunodeficiency. The pre thingy is online, so you can access it. We included 329 patients from 51 EBMT centres. So by a large margin, this is the biggest study of clinical allotransplant in adult PID patients. We looked at overall and event-free survival, and then we looked specifically at a number of secondary endpoints, including the impact of various PID-associated complications, such as bronchiectasis, colitis, splenectomy, genetic subtype, or the presence of autoimmunity or inflammatory lung disease, and previous PID-associated malignancy. I won't go through this in detail because I don't have time, but broadly speaking, the largest group of patients were combined immune deficiencies, so 50% of the patients had CID, 38% had phagocytic disorders, and 11.9% had predominantly antibody deficiencies. So these included, as per IUIS classification, CVID patients and APDS patients and a couple of XLA patients. I've got 5 minutes. Thank you. 5 minutes to 20? Yeah, okay, all right. And they broadly had, you can see here the sort of phenotype and the comorbidities of these patients at transplant. So the take-home message, the overall survival of these patients for the whole cohort was 75% at 5 years. The phagocytic disorder group, which had a large number of CGD patients, replicated previous CGD transplant data, that's the green group, was 78%. The CID combined immune deficiency, 68%, and the predominantly antibody deficiency was 59%. And these is a median follow-up of just under 4 years. So things that significantly impacted on overall survival are really important. The number of PID-associated complications at the time of transplant. So colitis, autoimmunity, malignancy, bronchiectasis, whether patients were on systemic immune suppression. The more complications you had, the worse you did. I guess that's not surprising. And now I can't make the... oh, I'm pressing the wrong button. There we go. However, age was not important either for overall survival or event-free survival. So when you see that patient, don't think, are they an adult, are they 30, are they 40, are they 50? Think, how sick are they? How many comorbidities have they got? How many complications? What's their, if you're a transplanter, what's their HCT-CI score, their comorbidity index? The rates of GVHD were low. Remember, this is over 300 patients. Most centres in Europe use T-cell depletion as part of their conditioning regimens, and almost all of these patients got either Campath or ATG for T-cell depletion as part of their conditioning regimen. So I think I've got a couple of minutes. I've got 2 slides on a great collaboration I've had with the Necker in Paris, led by Morgan Chemenon and Philippe Suarez. And we tried to do a case match control study. In the absence of a prospective randomized trial in adults with inborn errors of immunity, transplant or not transplant, which is, of course, the gold standard. You know, I can present this great retrospective data and say, actually, I think this is pretty good. These results are quite good. But, you know, the proof of the pudding would be a prospective randomized trial. Everyone knows, impossibly difficult to do in rare disease. So we took 79 index transplanted patients who've been transplanted in older adolescence and adulthood, and we matched them with up to 3 matched controls per transplanted patient, and they were matched on their age, their birth decade, the PID subtype, and the severity of their PID-associated complications. And they had a median follow-up of 4.8 years. We've just had the reviewers' responses back from our first revision in Blood, and we've got one more question to answer. So I'm not 100% confident, but I'm hopeful it will get accepted for publication. And the take-home message from this story is when you look at disease-free survival, the patients who had the transplant have a plateau. So you achieve a plateau. The patients who continue with conservative management alone continue to deteriorate. And that, if you look at the flip of that, using slightly different endpoints and look at the cumulative number of PID-associated events, you see in the patients who weren't transplanted over time, these continue to accumulate. So I'm going to finish with just two pictures from our own cohort at UCL. We have now transplanted 76 adults, and this is data updated from September when we had 68 patients. Proper inborn errors of immunity, our overall survival and graft failure, GVHD-free survival is excellent. There's no significant difference between the adults over 18 years and under 18 years. And what we've shown here is that pre and post-transplant, a reduction in recurrent infections. We've shown that patients who have severe warts pre-transplant, this is a patient with DOC8 deficiency. After transplant, they get worse when the patient's on GVHD prophylaxis. They continue to get worse. The patient thinks, why have you transplanted me? You've made me worse. I hate you. I never want to come back to clinic. And eventually they go away. And it's our experience with HBV-associated perineal lesions in patients with GATA2 is that it takes up to 5 years for those to clear. And then the final slide I'll show you, we were talking about that earlier, patients who have inflammatory colitis associated with PID, you see a really profound benefit of allogeneic transplant. So that's enough because I've gone over, and I'll show you the picture of my colleagues. Thank you.
Thank you very much, Emma. One question from the audience.
Thank you. So perhaps it wasn't statistically significantly different, but from your large cohort, the survival of the predominantly antibody defects seemed lower than the combined immunodeficiency.
Yeah.
That would be surprising to me.
No, because 27 of those patients in the predominantly antibody deficiency group were CVID patients. They had much higher rates of hepatic comorbidity and bronchiectasis. So those are the things that I worry about. So historically, the data of transplant for CVID adult patients is that their overall survival of 5 years is in the order of 50%. So actually, when you take those out, there were a couple of XLA patients and there were some APDS patients, and they were as good as the combined immune deficiency group. So I didn't show the slide that pulled out the CVID patients. I'll show you. That's in the paper. There's a table looking at that particular subgroup specifically, and they're the patients that still do worse. And I don't know if that's about patient selection or the underlying disease.
Thank you very much.
We go with worldly cytopenias in Hematology Oncology with Eleonora Gambineri, who is in Florence, University of Florence, Italy.
Okay, so let me see if I can. Okay. Thank you for giving me the opportunity of talking about a different topic, I would say. And this will give me also the opportunity to give you a different perspective on PID. So how do I go on? Like, does it work? Okay, I can go like this. Okay. So I would like to think outside the box. So rather than thinking of primary immunodeficiency, as we have heard earlier, like disease where they are prone to infections or to autoimmunity, I would like to start from other more unusual, let's say, presentation, like hematological presentation, and things from there, if they might open up some new diagnoses within the world of PID. So I would try to bring you into my talk and try to convince you that maybe the EMONC scenario can have nice red flag for primary immunodeficiency. So which is the scenario? In terms of hematological presentation, usually anemia and thrombocytopenia are the more typical symptoms and signs of an hematological disease in kids. And our hematological colleagues, they are very good with flow chart and the diagnostic flow chart and the assessment of these kids to see which is the best diagnosis and also the best treatment. In terms of malignancy, pediatric blood cancer, it surely accounts for 40% of malignancy in kids, and mainly acute leukemia and lymphoma are the main presentation. So, too many or too little? Let's start from cytopenias. So this is a nice cartoon from Marcus Seidel that summarizes a little bit in a clear way what cytopenias in PID where come from. So you see the autoimmunity and immune dysregulation, they are the major player of cytopenias in primary immunodeficiency, but also there is an overlap with bone marrow failure syndromes where actually myelodysplasia as well as telomerase problem can somehow overlap with immune dysregulation. And of course also myelosuppression which is most of the time drug-induced or virus-induced. So you all know that autoimmune cytopenias, failure to maintain self-tolerance, is the main mechanism that brings somehow to an immune-mediated destruction of differentiated hematopoietic cells. And these disorders usually are secondary to other conditions. So autoimmune, mainly autoimmune disease, drugs, or also infections. And Evans syndrome is an historical and descriptive terms to somehow describe the multilineage cytopenias, mainly autoimmune hemolytic anemia combined with thrombocytopenia, and sometimes also with neutropenia. And basically, around 50% of the patients with autoimmune hemolytic anemia, they also have another lineage involved. And it has been considered, it's a diagnosis of exclusion. So it's idiopathic if you don't find anything else. So it's a little bit like common variable immune deficiency. You really need to look for what is the cause. And here, when you think about Evans syndrome, you have to rule out, in order to diagnose Evans syndrome, infections, immune problems, and also, of course, malignancy or others, conditions like vaccination or drugs and so on. So the diagnostic workup goes through hematologic evaluation and infective screening, immunological workup, and also radiological evaluation to rule out maybe involvement of lymphoproliferation. And this recent report showed very clearly how these autoimmune conditions, most of the time, they're secondary to other autoimmune, more broad autoimmune disease, or maybe other conditions like bone marrow failure or myelodysplasia. So, do you still think that Evans syndrome is in an idiopathic condition? This is a nice paper from Alan Fisher from a few years ago, but actually I think it was quite a visionary paper, where actually they were trying to point out how autoimmunity is quite frequent in primary immunodeficiency patients, and in particular, as you see here, in autoimmune cytopenias, it has a higher risk, higher percentage to be represented within these diseases. That counts around the 30%, 32% of immunodeficiency, and they can be B cell immunodeficiency, T cell combined, innate. So it's quite a striking features. And that's why autoimmune cytopenias are one of the main clinical features also of this new category, I would say, of immunodeficiency that regards mainly an impairment of immune homeostasis, so the primary immune dysregulatory disorder. You know that the mechanism of autoimmunity in PID are various, so there is not only an impairment of those mechanisms that ensure the tolerance in the periphery and the central organs, so I would say defects of apoptosis, regulatory T cells, or impairment of IRE in the thymus, but there's also mechanisms that involve both B and T cell activation and development. So sometimes when you don't have a polyclonal response of B and T cells, but only oligoclonal response, these will prone, of course, to autoimmunity and not to a perfect control of the immune responses. So usually, when we see a kid with, let's say, an ITP or with autoimmune hemolytic anemia, do you think that this kid has an immunodeficiency? Well, usually I would say that normally, if it's only one lineage, and they tend to be self-resolving, and most of the time there is a secondary condition that causes the event, especially for immune thrombocytopenias. But if they're chronic or refractory and they don't respond to conventional treatment, then you should raise your suspect of an immune defect. And in the last, I would say, 5 to 6 years, there are several reports that somehow have noticed the fact that these autoimmune phenomena need to be better studied in terms of immunological workup. And few years ago, I had the suspect of looking a little bit more deeper and thinking outside the box when I had to manage this 9-year-old female that presented with very severe autoimmune hemolytic anemia. And basically, she came at our PICU because she had dropped her HB levels to 2.5, and she had basically CNS hypoxia and then an hemorrhage, and she had actually several issues related to the event. We try with several attempts of immune suppression to recover from the acute episode, and eventually we try with rituximab, with cyclophosphamide, with rapamycin, and also with plasmapheresis, and eventually she slowly recovered. Then we went back to her previous medical history and family history because we thought that it was a very unusual event, especially because it was not actually responding to conventional treatment. And we learned that 6 months earlier she had an episode of lymphoadenopathy that was not really well assessed. For sure, there was not secondary to an infection. And they did immunoglobulin levels, and they noticed, and they came out with a borderline hypogammaglobulinemia, but it was not noticed. And 2 years earlier, she was also investigated for chronic diarrhea, but nothing came out from the investigation. There was no evidence of malabsorption, and apparently it resolved spontaneously. So we have this very tricky autoimmune hemolytic anemia, unclear lymphoproliferation, diarrhea, hypogamma. If you take all these information into account, you are more convinced that maybe there's something that is going wrong with their immune system. And we did, at that time, a target panel for immune dysregulation, and we got a state 3 gain of function mutation that was already described in literature. So on rapamycin, she was able to somehow stabilize her immune dysregulation, and she was clinically well. She was so she recovered her hyperactivation from dysregulation, and we were able to transplant her with a match-unrelated donor, and she's now well apart from the sequela of her CNS hypoxia. At that time, the JAK inhibitors were not still considered an option, and we were start to talk about IL-6 tocilizumab, but she was doing well with rapamycin, so we thought to keep it on that until the transplant. So from there, I decided to try to find some clues to predict, let's say, an immune defect from a presentation of autoimmune cytopenias. And we studied more or less 30 pediatric patients in our hospital affected by autoimmune hemolytic anemia or thrombocytopenia or neutropenia. We did an extended in immunophenotyping and also next generation sequencing for a panel of PID known gene. And we wanted to see, to discover if there was a defect behind, but also trying to find some immunological indices that were predicting somehow some immune problems in this cohort of patients. So first of all, we divided two cohorts in patients who only had immune cytopenias with no other symptoms that can resemble a PID or immune dysregulatory problem, and then patient with immune cytopenias and suspected symptoms on sign for a PID. I would say recurrent infection, other autoantibodies or other type of autoimmunity, lymphoadenopathy or splenomegaly, and so on. And then for some of the patients, we also have data before treatment and after treatment. And of course, the treatment, apart from the acute disease that, of course, you treat either with immunoglobulins or steroids, then we learn from HALPS that mycophenolate and sirolimus are very good immunomodulators to keep to induce a remission of the disease. So from the immune phenotype, we found a significant imbalance between naive and memory compartments, especially in T cells, but also in B cells for some patients. And we also have a lowish, I would say, Treg compartment in this patient. You see on the bottom. And the other interesting thing is that for the cohort with a suspect immune defect, we did a PCA analysis of the T cell subset, and we found that after starting on sirolimus or MMF, so you see the big pinky area is shifting towards the center. That means that they are recovering some of their subset impairment, and so it seems like that there must be something going wrong in their immune system, that the treatment is solving the problem or at least keeping under control. A recent paper that just recently came out actually has similar finding that we have. So they also show that there is a low naive compartment, especially on CD4, and increased T cell activation as well as impairment of class switch memory B cells, and also an expansion of follicular T cells. The gene that we found associated to autoimmune cytopenias were mainly genes involved in immune dysregulation, but also on HLH, apoptosis, and so on. And you see that over time, several several PID have been associated with autoimmune cytopenias. So I only have 5 minutes, but I would like to tackle very briefly lymphoproliferation, which is another important symptoms of in the hematological hemonc scenario. So of course, it's an abnormal overgrown lymphoid tissue that can be just reactive or monoclonal and malignant, and LPD. We heard in these 2 previous days that actually it's an important symptoms of some of the disease that have immune dysregulation or autoinflammation. and can be also the first clinical presentation. The mechanisms are more or less the same. There is an impairment of control of T cell activation of T cells, or chronic lymphocytic stimulation, and so on. And the primary immunodeficiency who are mainly characterized by lymphoproliferation are mainly combined immunodeficiency or deficiency of immune regulation like ALPS or IPDS, and also EBV-associated disorder. And thinking about ALPS, we recently diagnosed ALPS in a patient who had a very extent lymphoadenopathy and very high biomarker. But the interesting thing is actually the mother was affected by the same disease, and no one noticed, had at least the idea of exploring ALPS for her. And so she has a very active disease with very high biomarker, especially double negative T cells, and she actually completely recovered and changed quality of life on sirolimus. Just to say that we have to notice these syndromes also if you don't think they match with a primary immunodeficiency disorder. So this big dilemma between immunodeficiency, lymphoproliferation, and lymphoma maybe will be resolved in the future, because what is the boundaries between polyclonal and clonal? I think the fitness of the germinal center is the main things to follow up over time. And also the lab, we don't have really biomarkers. There are lab tests that can be indicative of lymphoproliferation, like LDH, or as we heard from Kate, increase IgM in some of these patients. Imaging can help. But for sure, if we are able to diagnose a PID before a lymphoma or a malignant lymphoproliferation start, that will change completely the quality of life and the prognosis of the patient. So we know that primary immunodeficiency have a higher risk of developing lymphoma. B-cell lymphoma are the major, the more frequent lymphoma that usually are associated with primary immunodeficiency. So maybe we should start to think of malignancies as a warning sign. There are not very many cases, maybe a couple, described in literature where lymphoma was the first presenting sign of primary immunodeficiency. And actually, we had a boy with a disseminated lymphoma at 9 years old, and then he was cured and he was fine, and then he started to present with lymphoadenopathy again after 3 years. Everyone was completely, was very worried that it was a relapse of the lymphoma, but at the end it was only a lymphoproliferation that was also associated with autoimmune cytopenias and was controlled with sirolimus. Afterwards, we realized, we found the mutation on Icarus gene. So the lymphoma was the first sign of his disease. So non-Hodgkin lymphoma and PID can play the hide and seek, would say, game, especially because they both can benefit from each other. So if you detect an immune deficit in patient who has lymphoma, that for sure will change his prognosis, and maybe we can learn from lymphoma and try to extract some biomarker in order to follow up PID patient and see when is the time to develop a malignancy. And that's the focus on my current work. We already found some variants in patients that we tested with B-cell lymphoma. And I'm sure that we should talk to the oncologist and tell them that it's very important to assess this patient in a proper way with a proper medical history, because of course if you have manifestation, autoimmunity, infection of primary immunodeficiency in a patient that present with a B-cell lymphoma, T-cell lymphoma, or they have a very early onset or recurrent malignancy, you can maybe rule out all sorts of different conditions and change his quality of life. So, and with this, I I will stop, and I would like to thank all the people in my hospital and all the collaborators. Thank you for your attention.
Thank you very much, Eleonora. And are there questions? Something just to say, maybe lymphoma is not so common, but at least lymphoproliferation, leukemia, even if it is...
Yeah, that's sure. I mean, lymphoproliferation is something that in a hematological setting, you see patients that they come for this enlarged lymph node, and then maybe have been followed up by infectious disease people, and they didn't come out with anything. And yes, there is a question.
Cytopenias, I think, is very important for hematologists, especially young children, to think about.
Well, if you know that he has... Yeah, so she's asking if the prognosis of a patient who have a malignancy can be different if you know that they have also a primary immunodeficiency.
According to the genetic defect.
Oh yeah, of course. So it depends. If you find a genetic defect that you know that you won't be able to treat or keep under control over time, maybe some genetic defect, they will tell you, okay, even if that lymphoma in the treatment doesn't have to go to bone marrow transplantation, if you know that he has an underlying defect like that can actually not resolve over time, then you will you have more confident to approach the transplantation in the patient rather than not. That's the only differences that I would say. For instance, Icarus, so we were actually puzzled about this patient because he had lymphoma, he recovered, and now he's fine on sirolimus, but I'm a little bit, anxious because I know that Icarus defect, it's better if you transplant them, but he's a young teenager, he's doing fine, he has a normal life, and so what would you do? Maybe Emma can answer to the question.
Thank you very much. In the interest of time, unfortunately, we have to go on, and it's a real pleasure to have Kate Sullivan with us, who is coming from the United States of the Children's Hospital in Philadelphia, and who regularly comes to ESID summer schools, and it's always a pleasure to have her here. Thank you, Kate.
My pleasure. I'm actually going to go way back to Maria's introduction. Remember in her slide, she said 25% of children and adults with inborn areas of immunity do not present with infection. But how do we communicate that? How do we say that to our friends in the intensive care unit? How do we get that message across? How do we define the patients that we want them to call us for? That's really hard. So we heard about the hematologic issues from Eleonora. All right, Evans syndrome. That's a nice sentence that you can say to your colleagues, call me for all your Evans patients. But it gets really hard after that, right? So I want you to stop right now and ask yourself, if you were talking to your intensive care unit, how would you explain immune dysregulation conditions? How would you tell them what patients you want them to send to you? It's really hard, right? I struggle with that all the time. I don't think I'm going to solve it, but let me just break it down for you, because I do think messaging is really important. I think we're at a point in immunology where we have not perfect tools, but good tools for diagnosis. As Emma was talking about, we have targeted therapeutics for some of our patients. We've made a lot of progress, but we can't use any of that until the patient gets to our clinic. And so I think communicating who it is we should see is becoming more and more difficult and more important. So if you don't know where Philadelphia is, it's between New York and Washington, D.C. This is my hospital, and I work on a team called the DIRT team. DIRT stands for Dysregulated Immune Response Team. So I think about this problem all the time. We're trying to say to the pulmonologist, who is it that we should be evaluating for an inborn error of immunity? And as I said, I don't have an answer, but let's think about it together. And I'm going to start here at the very beginning where Mary started. So we would say this is a reasonable definition of an inborn error of immunity. Dysfunction of one or more elements of the immune system, right? We could agree on that. But what does that mean? So we've heard about infections today. So Peter talked about infections. That's a little more obvious, if even there are some ones that are hard to talk about. Herpes simplex encephalitis, some strange ones that are maybe harder to communicate. But then you get abnormal response to infection. What's that? So Despina is going to talk about HLH, which is like the poster child for a bad response to an infection. I'm going to focus on these bottom guys here, autoimmunity and autoinflammation, but also talk a little bit about abnormal responses to infection. And I think that's the group in that 25%. So when Mary was talking about the 25% that doesn't present with infection, what is that? Syndrome, family history, immune dysregulation. And malignancy. So I think we need to be able to operationalize what those patients need to have to be referred. Okay, so what, can we be more specific? We've heard about some of the hematologic ailments. Autoinflammatory, I suspect those of you from Greece have seen far more familial Mediterranean fever than I ever have, so I will leave that to you. There's kind of a group that forms polyendocrinopathy enteropathy. And by enteropathy, I don't necessarily mean inflammatory bowel disease. More often, it's a small bowel disease with villous atrophy and lymphocytic infiltrates, but can look like inflammatory bowel disease. There's kind of the waste disposal group of disorders, which are the interferonopathies and the complement defects. There's congenital atopy, which I find especially hard to communicate. I don't want to see every patient with asthma, but I want to respect that asthma is a common presenting manifestation for inborn errors of immunity, so I don't want to ignore that. I think atopy is a particularly hard group to talk about. I will talk about IBD. There's kind of the Behçet's lupus complex. Those, I think, actually turn out to be fairly easy because you're looking for early onset. But these are the ones that I'm going to try and cover, believe it or not, in 15 minutes. I'm going to leave HLH to Despina, and we've already heard about lymphoproliferation and a little bit about malignancy. So this, everyone has been talking about this so far for our 2 days. This is the IUIS list, not the one that just came out because it wasn't graphed, but we're up to almost 500. And what I've done is I've listed in red the bar for immune dysregulation. You can see it's not going up faster, it's going up along with all of the others. So this is the paper that Mary was talking about. This is from the French group. Sorry, it's from the ESID registry, sorry. And it is the gray and green bars. I'm not sure if my little arrow works here. Does it? No. So it's the green and the brownish ones. You can see they don't change with age. You might have thought that immune dysregulation was more likely to occur in childhood, not necessarily. So again, this is what Mary started with. 25% of patients with inborn errors of immunity present with non-infectious features. I do have a pointer. Thank you. Can I use it and talk at the same time? So what I want to just, again, is that we as a community need to be able to communicate who it is we need to evaluate. I think we do a reasonably good job of evaluation, but we have to get the patients to us. So who should be worked up? Inflammatory disease, autoimmune disease, atopic, what should the workup consist of? These are all things to think about. I'm going to start with fevers, and again, recognizing that those of you from Greece know familial Mediterranean fever 1,000 times better than me. I have taken the easy way out, and I'm going to focus not on FMF. So when you see fever, and the thing I like to ask the parents is, does your child get fever without any respiratory symptoms? Does your child get a fever when no one else in the household has anything? Those, to me, are signs that it might be an autoinflammatory disease. Non-FMF things, particularly in kids, are fevers with a consistent rash. This is a picture of a baby with CIAS1. Developmental delay or loss of milestones. This is quite common in the interferonopathies. So what can you do? You can, in the US, typically the rheumatologist will just give an IL-1 inhibitor and ask, does it do anything? I think that's okay. In the Mediterranean, you might try colchicine by the same token, or you can go with genetic testing. I think any of those are defensible as first-line approaches. What about autoimmunity? So we've heard about this a little bit already. I'm going to start with lupus. So I would not say that it makes sense to work up every lupus patient. In adult lupus populations, the likelihood of finding an inborn error of immunity is about 1%, and that's in Caucasian groups where it's likely to be C2 deficiency. You will also find some lymphocyte disorders periodically, some in the apoptosis pathway, some in signaling pathways. But when you get down to early onset, so when you get down to onset less than 5 years of age, the likelihood of finding an inborn error of immunity goes up to 80%. So here, age is the main thing. Eleonora's already talked about Evans syndrome, quite likely to find an inborn error of immunity. So these are situations that I think are relatively clean and crisp to communicate. If you see lupus before 5 years of age, I want to see your patient. If you have Evans syndrome, I want to see your patient. I think those are easy. And just expanding to the larger rheumatology clinic, here they compare juvenile idiopathic arthritis, lupus, vasculitis, and mixed connective tissue disease. You can see the highest likelihood is in lupus and vasculitis. I think vasculitis is a bit harder to talk about, to be honest. What about gastrointestinal problems? I happen to work in a joint clinic with gastroenterologists that see early onset IBD. I'm not going to talk a ton about it because the epidemiology of inflammatory bowel disease is very different in different parts of the world. You might not know the United States has the highest rate of inflammatory bowel disease compared to anywhere in the world, and by far, not just by an increment. So I think our situation is possibly a little different than in other parts of the world. But I did go through and use the US registry and just ask, where do you find IBD? Red is IBD, and for comparison, I picked autoimmune hemolytic anemia and ITP, and then you'll just see different diagnostic categories. You can see sometimes there's IBD by itself, and sometimes it's with all other autoimmunity. In the way that Emma was talking about, where you see these patients and it feels like they just have every organ has autoimmune disease, that's really a sign that there's an inborn error of immunity. This is a paper that Eleonora just cited, but I plucked out a different table. So this is looking at the relative risk of each of these autoimmune conditions in an overall PID cohort compared to the general population. So autoimmune cytopenias, by far the highest relative risk, but look at IBD, pretty darn high. So you do want to pay attention to inflammatory bowel disease because it is such a strong indicator of an inborn error of immunity. And this is how I think about it. Again, because I work in an early onset IBD clinic, I tend to think about this type of gradient where the earlier the onset, the more likely you are to find a monogenic causality. In our clinic, that goes hand in hand with severity, and I spend more time with the non-monogenic cases than I do with the monogenic cases. So here's a differential for essentially IBD from a gastroenterology textbook, sorry. But I would say they kind of missed the boat. I think they need to be thinking about immune dysregulation conditions. Yes, there are all of these other causes, including infection, but none of the textbooks list immune dysregulation, and I think that's a mistake in this day and age. So what do we find in our clinic? I'm quite sure you can't read those fonts, but I'm just going to tell you the top 2 diagnoses, other point here. These are the ones that you can diagnose by flow cytometry or immunoglobulins or a dihydrorhodamine. You can see it's a relatively small number of these conditions. And that was a surprise to me. When I started in this clinic, I did standard immunologic evaluations on all the patients. Very unrewarding, I have to say. But we do want to know about the genes, and we use genetic testing in that clinic now almost exclusively. We do a dihydrorhodamine because the second most common diagnostic category for us is CGD in this clinic. But past that, we don't really do flow cytometry or immunoglobulins. And why are we so focused on genetics? It's expensive, it takes a long time to come back. It's because, as you've heard from multiple people here, knowing the gene is your ticket to precision therapy. So once you know the gene, you know if you should be using a JAK inhibitor, a beta sept, rapamycin. So we use that quite a bit, and we do transplantation. We try to transplant all of these. We don't always have a donor, maybe the family's not interested, but for these categories, we try to transplant them. Sequencing can also tell you what not to use, so we tend not to use TNF inhibitors because of the high risk of fungal infections. How are we doing? All of our transplanted patients, thankfully, have survived. As Emma said, the IBD melts away. It's one of the most rewarding things on the planet. And it's really the way we convince people to go for transplant. We also have access to an IL-18 binding protein called Tadakinib that's used for XIAP deficiency and NLRC4. It works brilliantly. I don't know how long we'll be able to get it. And in these cases, sometimes we've had to be really creative to prepare them for transplant. And what do I mean by that? We have to use multiple drugs. You want the disease to be as calm as possible. You want the nutrition to be as optimized as possible. And sometimes it takes a little work to get there. Now, this is the group that I think is especially hard. So I've called it pleomorphic autoimmunity. Emma talked about it a little bit. She said, you know, once you start adding up autoimmune disease, boy, it's time to think about genetic testing. These conditions are not well or easily established through flow cytometry. You might see low immunoglobulins, might not. So I personally think that sequencing is especially important. But getting back to my thesis, we have to be able to tell our friends in rheumatology, gastroenterology, hematology, who it is we want to see. And I think for me, once someone has autoimmunity in a way that is either treatment resistant or it doesn't make sense, right? We know what lupus looks like. We know what rheumatoid arthritis looks like. Once you have autoimmunity that doesn't have a name, affects multiple organs, or is treatment resistant, that's time to think about an inborn error of immunity. So here's how I would say it. I would say early onset lupus, early onset inflammatory bowel disease, and then very unusual autoimmunity where you just can't give it a name. Those are the ones that I think deserve genetic testing. So let me just move on to another really hard topic, and that's A to P. We know there are monogenic conditions. You've actually heard about that. So Fabio today talked about the actinopathies. They have a lot of sort of A to P as part of them. Not so much food allergy, but often eczema, sometimes true IgE-mediated allergies. Those hyper-IgE conditions are really important to define because they have bony abnormalities, vascular abnormalities. It's not necessarily the A to P that you can fix, but you need to monitor them for all of these other problems. So seeing someone with early onset severe A to P, or again, really unusual A to P that doesn't respond to treatment in the way you think it should, for me, those are signs to work the patient up. And they sort of fall into 4 categories. There's the hyper-IgE group, which I think is the easiest to conceptualize: delayed shedding of teeth, bony problems, infections of the lungs. There's the Wiskott-Aldrich group, which is part of the actinopathies that Fabio talked about. Those tend to have platelet disorders, so not so hard to find those patients. Eczema and eosinophilia occur in some classic immune dysregulation conditions. And then Omen's syndrome is kind of a special case that hopefully no one would miss. So I'm just going to summarize that what you already know, we've been talking about it all day. Inborn errors of immunity can present in many different ways. And you cannot memorize everything, even me, and I'm on the committee that tries to memorize everything. So you have to put it into patterns that not only we recognize ourselves, but we can communicate to our colleagues. So the infections, and do remember single organism susceptibility. I think we get caught up in this idea of recurrent sinopulmonary infections, and we forget pure susceptibility to herpes simplex, pure susceptibility to EBV. We need to be able to communicate that. The autoimmunity that I've talked about, other immune-mediated conditions like A to P, always think about family history and consanguinity. And then I didn't talk about syndromes, but we always, I think our radar goes up when the child has syndromic features. So recognizing how hard this all is, I want to leave you with some resources. So here's a few for you. So the Immune Deficiency Foundation has a consulting immunologist program. The CIS listserv in the United States is not restricted to the United States. You can always post a case there, and people will offer you opinions. You can always email me. I'm going to show you a website called Immunodeficiency Search. I'm going to show you a cell phone app that you might know about. The links are there. This is the cell phone app that comes from the IUIS list. So Aziz Boussifa, every time we put out a publication, he puts it into this nice phenotype, and it appears as a cell phone app, And if you look for it, it comes up as PID phenotypical, and then you want to look for that little icon and download it. And you can search for different phenotypic manifestations. I think people like it because it's on a cell phone. This one is on a desktop. It's not available on a cell phone, but look how aesthetically pretty it is. It's quite nice. So it talks about, I'm sure it's quite hard. Hopefully that gave you some resources that you can use when you're really stuck. We all get stuck. Please don't ever think none of us get stuck. We all get stuck. So thank you, Efkalisto.
Thank you very much for this great overview. So we have time for a few questions. One question.
I know you're in a rush.
Okay.
Yeah, thank you for the talk. Do you have any idea where this high rate of IBD in the US comes from in comparison to all the other countries?
So bad living, I'm sure. I think it might be our diet. It's so processed, but I don't really know. But there's this series of papers, I don't know if you've seen them, called The Global Burden of Disease, and they look at different diseases. When you look at the IBD version of the Global Burden of Disease, they almost need a second graph for the US. It's way at the top and everyone else is down here. So it's quite bad. I don't know what our cause is, but it's dreadful. Okay.
Thank you again, Kate. So it's a pleasure to have Vivian Maggina, who works with Maria Kanariou here in Athens, to have her talk. So please.
Thank you for your kind invitation. I would like to thank you for being here and welcome you in Greece and in ESID Children's Hospital. I'm here to present a very interesting case report that has been diagnosed in the first department of pediatrics of ESID Children's Hospital with the collaboration of many subspecialties, and this is something that I would like to emphasize. Our male patient has been admitted in our clinic on February 2021 at the age of 2.5 years with a generalized petechial rash that has been appeared 8 hours before admission, and also low fever up to 37.8 for 24 hours 3 days ago. Upon his medical examination, he was on poor general condition. However, his vital signs were normal. He had eyelids edema, pallor, the whole body generalized petechial rash. We also found out hepatomegaly and splenomegaly. In terms of his weight and height, he was within the normal range for his age. Regarding the personal history, he was born at 33 weeks of gestation with a cesarean section and with a low birth weight. And 6 months ago, he had been diagnosed with hypothyroidism, and he was on medication ever since. As we searched for the family history, we identified some non-specific autoimmune disorders in maternal family that had not been diagnosed and treated specifically. In regards to his laboratory findings, he presented with severe hemolytic anemia and thrombocytopenia. He also had very increased levels of glucose in blood and urine. He had low levels of total protein and albumin in blood, which in combination with the detection of high levels of calprotectin in stools led us to the suspicion of a possible leaky bowel syndrome. And of course, we had the abnormal thyroid gland function that was already known. With the help of Dr. Kanariou, we proceeded to an immunologic workup. We found low levels of immunoglobulins. From the autoantibodies tested, we detected positive antibodies against the pancreatic cells. And regarding the lymphocyte immunophenotype in peripheral blood, we found normal numbers of lymphocytes, normal numbers of T cells, increased numbers of B cells, decreased numbers of NK cells, but the more significant findings had been the increased numbers of T regulatory cells and the increased numbers of T4 and T8 memory cells. So, to sum up, our clinical and laboratory findings in our patient included autoimmune hemolytic anemia and thrombocytopenia, a red flag, Evans syndrome, as mentioned before, autoimmune diabetes mellitus, a strong implication for leaking bowel syndrome, and autoimmune hypothyroidism from the clinical findings. And from the laboratory ones, we had low immunoglobulins, significantly increased numbers of T4 and T8 memory cells, and very increased numbers of T regulatory cells. All these findings directed our clinical and diagnostic thinking towards a possible autoimmune manifestation with an underlying immune dysregulation mechanism. So we had a very strong suspicion of an underlying primary immunodeficiency. For this reason, we asked for a genetic testing. Of course, while awaiting for the genetic testing, we had to treat the very severe and possible life-threatening clinical manifestations of our patient, meaning the hemolytic anemia, the thrombocytopenia, the low levels of protein and the increased levels of glucose. For this reason, we had to administer IVIG at a dosage of 1 gram per kilo twice, methylprednisolone at a dosage of 2 milligrams per kilo. We had to give a red cell transfusion. We had to provide intravenously, of course, human albumin, and to regulate the glucose levels with the use of insulin. Our patient had been successfully treated and has been discharged. Of course, after his discharge, he was on a very close follow-up, and he was on medication with prednisolone for 2 weeks and gradually tapering for the following 2 months. We also provided omeprazole orally. We continue to regulate his diabetes mellitus with the use of Novorapid and Lantus. Of course, we gave thyroxine and filicin. And during the follow-up period, we had to also add to his treatment an immunomodulatory therapy, and we decided to use mycophenolate mofetil. During that follow-up period, we had our result of our genetic testing, which was positive. We found a pathogenic mission at the CTLA4 gene, which is strongly related to autoimmune lymphoproliferative syndrome type 5. According to the IASO classification of human inborn errors of immunity, this disease is classified to the group 4 of immunodeficiencies, meaning diseases of immune dysregulation. CTLA4 deficiency follows an autoimmune somal dominant mode of inheritance, and it is characterized by a wide spectrum of clinical manifestations, including autoimmune cytopenias and enteropathy that have been found in our patient, but as well other manifestations as well, as interstitial lung disease, extralymphoid lymphocytic infiltration, recurrent infections. A very important finding of this primary immunodeficiency is the impaired function of T regulatory cells, which is characterized also by their increased numbers. We have decided and discussed very closely with the patients with the parents, of the patient, about proceeding to the stem cell transplantation. But during the period that we had to wait until the appropriate donor to be found, we had our patient on a very close follow-up. We continued to treat him on mycophenolate mofetil. We had a successful prednisolone tapering. We continue to provide a replacement therapy of immunoglobulins. It is very important to note that during that period, our patient had normal blood levels of glucose with no need for further insulin replacement, and he also did not present any other episodes of hemolytic anemia or thrombocytopenia. However, on June 2021, he had a severe episode of diarrhea following a course of chronic diarrhea with mild symptoms. We isolated an enteropathogenic Escherichia coli from his stools. We treated our patient with cotrimoxazole. However, he didn't improve significantly. He continued to have poor weight gain and a periproctic eczema that was severe. On December 2021, we identified increased levels of calprotectin, which in the previous period have been found low. We had to proceed on gastrointestinal tract endoscopy with no significant findings. However, from the stool culture again, we isolated an interesting pathogen, Candida parapsilosis. We treated our patient with funcostatin, and he had a significant clinical improvement and weight gain. On December 2021, the patient has been again admitted to our clinic due to severe abdominal pain that was caused by episodes of funtasusception, and it was likely that he had been treated successfully with no invasive measures. Finally, on January 2022, and after a matched unrelated donor had been found, we proceeded to stem cell transplantation that took place here in Athens in the Oncology and Transplantation unit, with the very important guidance of Dr. Grafakos, who is an hematologist in our clinic. Until now, the child seems to be doing well. Of course, he is still very close followed up from the doctors in the stem cell transplantation unit, and we are hoping that we have the best results. Thank you for your attention, and myself as well as Dr. Kanariou, we will be happy to answer to any questions.
We need to finish at 6:30, and I need to speak. So okay. Because we have still time. If you want to. So I didn't understand. So you want me to have first the questions, or you want to present something more? Okay. So you will complete the presentation. Go ahead, please.
Just a few points. Actually, I'm very lucky because Kathleen, Dr. Sullivan has already spoke about immune dysregulation, so it is much easier for us, Vivian and me. So it is known that already almost 20 years that there are complications and manifestations that primary immunodeficiency patients can present it with a combination of symptoms, and we have to be aware on that. You have already heard about it, and just to say a little more specifically about CTLA-4, that it is between, T-cell and antigen-presenting cells. This communication does not work correctly, and we have to continue the clinical presentation. It is, you have see the phenotypical guide in order to diagnose. Here is starting from the genetic point, the genetic result. What do you expect for having when you have a CTLA patient with inborn error of immunity. Something that, I do think that we don't have to separate infections and other symptoms or infections and other symptoms. The basis is inborn error of immunity. It is a common group that could present it in majority with infections, and there is a certain percent, significant percent, that has other kind of communications. And I do insist what Kathleen said, that especially if you have autoimmune disease in early age or autoinflammatory bowel disease less than 5 years, you have to think about the background that could be a primary immunodeficiency, could be a genetic defect. And before you start therapies, all other friends, as you said, Kathleen, rheumatologists, hematologists, and gastroenterologists have to communicate and to think about how to proceed in order to have the early diagnosis and the proper patient, the proper therapy for our patient, especially in young age. And I leave this. For the CTLA-4, there was a Nobel, one of the two persons, for James Allison, who had the half Nobel for this. And, okay, I leave this one. Thank you.
So thank you very much with this interesting case, who really wraps up what has been said before and with your summary about it. So are there questions from the audience? So I will start. Yeah, I mean, if we leave, we have some minutes for you, and if there are questions to this. You don't want to? Okay. So I would just say that you said something in the end what was very important, that the early age is a very important point. Also, Eleonora, she spoke about the recurrent and therapy-resistant cytopenias, but I think a very important keyword is also the very early untypical age, where you don't need to wait that it is resistant or recurrent. You just go ahead to filter out these hypomorphic SCID patients who may start with a thrombopenia at 3 or 1 or 2 months of age. This does not exist, so you need really to...
Even there is a baby at this age that had no investigation, and afterwards, after rituximab and all this, you don't know what was before the rituximab.
Yeah, this is why you need really to have the workup before you start, how to say, treatment that may interfere with the immunophenotype that can help you initially to go back to have an idea on diagnosis. If not, it's left to genetics. So maybe
you know everyone. Despina from Paris, Necker, and ISERM, and so many institutes that you have. I don't know everyone. Thank you.
So thank you, Maria. It's really a great pleasure to be here, and we have planned this so long, for many years, and I'm so happy that we have this window in the pandemics which will follow to meet here. And so I try to be in time, but I really want to talk about one of my favorite topics, which is primary lymphohistiocytosis, and point out the diagnostic challenge that you may have when you meet these patients, and sometimes you even don't know that you meet them, and this is why I'm here. So you all know these quite general clinical features. I'm not going to go into detail of this. And the biological features where I will have the real criteria that will come up later on. And these are patients that when they are young, as this very young infant, very soon will be critically ill. And this is really the challenge that HLH will start from a point where it is almost imperceptible, and then it can go on in very few hours, days, and be fatal if you don't filter these patients out. It's always the question, is this primary or secondary HLH? Because as you all know, infections may trigger all the kinds of diseases which can be accompanied by HLH. I'm focusing on the primary forms of inborn errors of immunity, but also metabolic diseases, malignant diseases, and rheumatological diseases can go ahead with, along with HLH. And so when we speak about familiar forms, these are severe genetic diseases, roughly 1 in 50,000 live births. In the absence of treatment, they will be fatal, and there is, for most of them, an early onset, which can be really in the first year of age, sometimes neonatal, even prenatal forms with ending of pregnancies due to HLH. But, and this is very important as a first take-home message, there are also late onset forms and even adults who have been not quite ill until having their first diagnosis. And most of them are autosomal recessive. And I point already out that there are often neurological manifestations that go along with this. We all know now that it's immunological disease, inborn error, and this is the common basis in a normal individual. Upon a viral infection, you will have expansion of CD8 positive T cells which will be activated in order to complete their mission, which is to kill the infected cells. And as soon as this clearance of the virus is achieved, immunity calms down, some memory T cells will remain in the body. In an individual with HLH, upon viral infections, but especially for the neonatal forms, without any objective viral or other infectious trigger, CD8 positive T cells will be activated. They can't complete their missions, and they will secrete more and more interferon gamma, which will activate the macrophages, which in their turn will and I show, and no one sees the flash, by the way. So these macrophages will more and more produce pro-inflammatory cytokines, and this leads to a vicious circle where more and more activation of macrophages and CD8 positive T cells will occur, and these cells will infiltrate the tissues and will show all these signs clinically and biologically of HLH. And essentially everything is caused by this hyperinflammatory state, the fever, the pancytopenia, elevated triglycerides, and so on. And the hallmark is the infiltration by these activated lymphocytes and histiocytes with the sign of hemophagocytosis. And if you would do what you can't ever do, a liver biopsy in one of these patients, you would see the activation markers, TNF-alpha, EL6, the CD8 positive T cells, and the high amount of interferon gamma. And so there are diagnostic criteria for HLH. This is a very pragmatic view of having an urgent diagnosis. And so if you have 5 out of these 8 criteria with fever, splenomegaly, at least 2 cytopenic conditions, high triglycerides and low fibrinogen, hemophagocytosis in the absence of a malignant or rheumatic disease, absent or low cell function from natural killer or T cell function, hyperferritinemia, and high EL2 receptor or other activation markers. And so then you can say that this is an HLH, and you can go on to treat these patients without further waiting, because in the severe forms, if you wait, you will lose the race against the disease, and you can't wait for genetics, or in most of cases you need to treat just because you are convinced that it is HLH. Whenever you have ruled out in the older patients that it is not a malignancy or a rheumatic disease. And so on the heart of the pathophysiology is the problem in lymphocyte cytotoxicity. And so you see here as a lymphocytic T cell. He's meeting its target cell, and there are lytic granules which need to go close to this immune synapse. And so these granules will move to this zone, and then there will be the exocytosis of the lytic content, and this will lead to the lysis of the target cell, and it is this mechanism that is defective in primary form of HLH. And so the first form of lymphohistiocytosis was said to be on chromosome 9. This was an old article, 8 of the 90s, but actually no one found ever the gene in this region, and this is why the classification starts with type 2. So there is a virtual type 1, but I don't know the gene for it. So we have here on the top again the lymphocytic T cell, on the bottom the target cell here, the immune synapse, and you see this mechanism where perforin-containing granules need to go to the synapse, and at each step there can be defects in genes, so you have the type 2 perforin deficiency, type 3 MANC13-4, type 4 and 5, two molecules that need to interact together, syntaxin 11 and MANC18-2. And so you have here type 2 to 5, the genetics. And I just want to have 2 words on perforin deficiency, so type 2, which is an important molecule because it's convenient to sequence, only 2 exons, and you can have if the patient has the good idea to come in prior to a Friday evening, you can have the perforin staining in the, at the moment when the patient comes in. Here you have the control where you see positive perforin, and here you see the patient where has virtual no perforin. And so this is also an important gene because there's one of the only situations where we have one of the rare situations where we have a clear genotype-phenotype correlation, because in the absence of perforin, HLH will arrive really early in life, in the first months at birth, in the first 3 months, whereas missense mutations with complete loss of function will still manifest very early. And then there are missense mutations where partial activity is retained, and these forms are very tricky because they will manifest later in life, and their EBV or other viral triggers will have an important role to get the HLH started. And so I want also to have 1 word on this form with the 5th form with MANC18-2, because MANC18-2 has the nasty property to be also expressed in the apical membrane of the gut. You see it here, because it's also called STXBP2 for syntaxin binding protein 2, because one abbreviation is not enough. So MANC18-2 and this one is the same thing. And you see that in a normal cell, this is very important for the gut to do all the exchanges. And if it's not present, you see that the apical membrane of the epithelium is completely disrupted. And this means that these are patients who have they have enteropathy from birth. And unfortunately, it's not a dysimmune problem, but a morphological problem. So this means that the patient will remain with his enteropathy after a successful transplantation. It will not resolve. And so you see what this will do to your gut. This is a normal situation, and this is a patient with MANC18-2 deficiency. And there are other genes that come up who do a hyperinflammation of the gut, like NLAC4, and they can also do HLH. And these are also molecules that are important in the gut epithelium, and in this case, what's interesting that IL-18 is a very important messenger of the dysregulation. Some words to X-linked form of HLH predisposition, which is the Portillo syndrome. So you have this impressive genetic workup which led that the XLP1 was found. So the subdeficiency, male patients, if there's not a very consanguineous strange condition where you can have females, so be aware of this, that will have, who will have HLH upon EBV primary infection, but they also will develop lymphoma. Whereas XLP2 patients who are mutated in XIAP, they don't have the problem of lymphoma, but they may develop colitis, inflammatory colitis. And so I skip this. And what's very important for the XLP2 and 1 patients is that they may present EBV-induced Haemophagocytosis, lymphoproliferation in the brain. This can be sometimes very difficult to be treated. Some more ideas on this clinical presentation with this case of a 10-year-old boy who came in with fever and cytopenia, 54,000 platelets, anemia, and polynuclear neutrophils were not so bad. And he had first bone marrow, which was normal. He was treated with antibiotics, and then the cell counts get worse, and he was developing hepatosplenomegaly. They changed antibiotics. They changed from the local to the regional hospital. He was getting worse and worse, becoming really neurological alterated with hepatitis. Ferritin not so important, 290 triglyceride, just above the range. The lumbar puncture found elements, too much events, high proteins, and he developed seizures. And this patient had this brain MRI, which was catastrophic, with all these hypersignals in the white substance. And he had also another particularity. He had silvery hair. And if you do this in English, Google will tell you at once that you need to think about Griscelli syndrome. If you do it in France, cheveux argentés convulsions. In the first place, it's just some fancy things who come out. But if you then add the right keyword and you say it's a disease, then you find again what you need to know, and you need to go out of this room not to forget about it, that some patients have the diagnostic clue in front of your eyes because they have partial albinism. So you have Griscelli type 2, you Higashi syndrome, and Hermansky-Putlag type 2, and they all have abnormal pigmentation in the hair. When you look onto microscope, here you also a hair. And this is a normal distribution. So we really don't need to forget about those. So this is Griscelli type 2 with also the trafficking of the vesicles, which I already showed you. And the Shidiaki Higashi patients, they have very large granules, and you essentially can also see it already in the smear of your peripheral blood. Sometimes the hematologist will call you and say, your patient has strange things, and this is already the diagnosis of HLH. You have it here in front of you. And so you really need to pay attention to these cerebral manifestations. This was a girl of 4 years of age. She had no other clinical manifestation or biological manifestation besides ataxia. And you see this horrible brain MRI. And so we did not really know how to treat her. This was when I was resident in Germany, and we did even do a brain biopsy, and you see here T cells around the capillaries. So we thought it may be vascularitis, and so then the paper from the group of Genevieve came out that some of these hypomorphic perforin mutations may have a predominant neurological involvement without having all the full-blown HLH criteria. And this was a perforin negative patient. This is a control. Here you see virtually no perforin. So the diagnostic was quickly done when you think about it. And so this patient was transplanted and was doing well with some sequelae, but not too bad. And so each type of all the diseases that I showed can have a neurological impairment. You really don't need to forget this, because this can change the life of your patient. I will briefly resume the clinical presentation from what I told you up to now. So you may have these patients with pre- and neonatal onset and very strong HLH that can take them away in a few days. And these are patients with perforin 9 mutations or MUNC34 patients. More the mutation is hypomorphic, more it will develop later in life, and the intensity of HLH may be less at onset, and it will take time to have the full blow-up. And more viral triggers like EBV or others will become important to drive the HLH. If you have a colitis, you need to think about MUNC13-9 mutations, but there are hypomorphic patients who don't have this, and they may be adults when they arrive at some point. XIAP is also a strong keyword in about 20% of the patients who have colitis, but then it's also important to think about EBV, which will drive the HLH. Sub-XLP type 1, it's the lymphoma, and these patients need to be ideally transplanted preemptively. If you have one family history and you find a young boy of 14 years who ignores that he is a carrier, I tend to make them come into the hospital. I say, well, you don't know me, but I know you, and you have a disease that we need to transplant you. It's a bit aggressive, but if you see what's happening to them when they get into EBV-driven HLH at the same age, and how many months you, this is for me, and I'm going to speed up, you really need to think about preemptive transplantation. Syntaxine 11, I didn't speak about it. And so albinism is a keyword which is really important. And don't forget about the neurological isolated form, because these are patients that are really, really difficult to filter out because they can lack any of the other signs. So you need to have an experimented neuroradiologist to look at the pictures of the MRI, and please do an MRI with injection. And if you are not sure about it, please seek a friend, because if you treat the patient timely, you can have a complete reconstitution. If you don't treat him timely, he will have sequelae or eventually he will die. So you have understood that HLH, the activation can take very strange ways to develop. And I'm not going to do much words about this case, but you see this is an 11-year-old girl who has never had nothing, and then she comes with this strange lung thing. She has fever, she has hepatosplenomegaly, she has a bit of cytopenia, but not too much. And so they have some, they look for infections and so on. They don't find nothing, so she responds to steroids. Second episode, some months later, again the lung, and again steroids. So some investigations are done, and she has activated T cells. She has normal perforin. She has a degranulation assay which was said to be normal, but she still continues 9 months, still the lung, again corticosteroids, and then it's the brain which is speaking. And you see this extensive brain lesions. We are now 19 months after the first episode. And then it comes, and genetics shows that it's lymphohistiocytosis with already known and predicted deleterious variants. So just don't think, don't wait too long. Go to genetics, because the clinical picture can be quite strange, and you really need to rule it out, because you can cure these patients by bone marrow transplantation. So the lung may be a localization of HLH to the brain. There are rubella strain vaccine-induced granulomas who have been described, and all this needs to be taken into account. And then the management, just last slide, you need to control. You need already to have the idea of this diagnosis, and then you refer the patient to a reference center. There are several approaches. I'm not going to go into detail onto this, but you can cure the patient. You can control the activation, and then you can proceed to the second step, which is allogenic bone marrow transplantation. And it's very important to bring the patients at the best remission to transplantation, because this is influencing the rate of survival. And with this, I thank you for your attention, and it's always many people who contribute to all this. And, well, I've done 20 minutes, so I will not have questions, but I thank you for your attention.
Thank you very much.
I have a couple of patients with autoimmune cytopenias, with Evans syndrome, with a heterozygous mutation on UNC13D. So do you have the same experience? There is some scattered report in literature. Do you think it's consistent?
Well, I would be suspicious, and I would maybe try to have protein expression or at least cDNA analysis. I've been asked for my advice for a patient who has died at 5 months of age with a full-blown HLH. And so genetics found one known variant, deleterious, and not the second one. And so the first genetic advice for this family from a genetician was, well, we didn't find a second variant, so there's no risk for this family to have a second child. And then I said, no, go for cDNA. And we found a second hit in a sequence which had not been, in an intronic sequence which had not been filtered out. So, I mean, if you have more hypomorphic forms, you may even end up to have cytopenia persisting episodes, and
that's all. I mean, because they don't have any other feature of HLH.
Yeah, but I would try at least to go further to be sure that there's no biallelic thing. Nevertheless, even if you have a first result with just one variant.
Okay.
Okay.
Other question? Are you going to have some comments?
Yeah, I have a mic here. Thank you. You can keep it. So we managed to finish in time. We still have 2 minutes left until 18:30. So I'm really happy that we finally succeeded to have this joint session. And I don't know how many people were able to connect, but it's really a great idea to do it this way, so that also other physicians who can't join physically can take profit of this kind of interaction. And so, yeah, I don't know. I'm thanking you very much, Maria, for your hosting us. Yeah, it was the first time that we did this, and we will see with the young and old summer school participants how they feel about it, but I'm very happy that we did it, and so thank you all for this very interactive, lively session, even if we did not have so much time for discussion. Thank you.